Hi, good afternoon, good evening, good morning to everybody around the world. Our speaker, Dr. Leorey N. Saligan, has been a nurse for 26 years, evolving into various roles from staff nurse, nursing faculty, advanced practice nurse, and currently as a nurse scientist in the Division of Intramural Research of the National Institute of Nursing Research within the National Institute of Health in Bethesda, Maryland. He serves as the Chief of Symptoms Biology Unit and as the Acting Chief of the Symptom Science Center, the second nurse that has been awarded tenure as Senior Investigator since NINR was established within NIH. As a nurse scholar, he makes highly visible contributions to nursing by initiating innovative clinical skills, translating laboratory discoveries into practice. He's currently the principal investigator of 5 clinical studies and has published close to 100 manuscripts in high-impact peer-reviewed journals. His clinical studies merge state-of-the-science methodologies to understanding the pathobiology of complex symptoms. He holds a U.S. patent for a genetic marker of cancer-related fatigue based on a discovery from his laboratory investigation. Further, he models strong collaborative interinstitutional and multidisciplinary relationships to advance symptom science, as well as create opportunities for students interested in nursing research and scholarship. In addition to his publication record, he has been asked to conduct scholarly presentations on translational research by various research societies, academic institutions, and professional organizations not only across the United States, but also internationally. He is a recipient of several recognitions from national and international organizations and multidisciplinary groups. He was awarded the Early Career Investigator Award by the Fatigue Study Group of the Multinational Association of Supportive Care in Cancer. He is an excellent mentor, where postdoctoral students who rotated in his laboratory are now holding assistant professor positions in various prestigious schools of nursing across the country. He is a recipient of competitive NIH grants to pursue his own line of research, a fellow of the American Academy of Nursing. Ladies and gentlemen, please welcome Dr. Leorey Saligan.
Hello. Wow. Is that real applause or really nice?
It's real.
Good afternoon, everyone, and thank you for this invitation. It's really an honor to join you. And I'm just going to go on, through these slides quickly so we can have a little more conversations. I like more of an interaction to really get to know our work and introduce my activities in NIH. This presentation is more likely an introduction or an overview of another expanded role of a nurse, which is being a nurse scientist. So uniquely, this is particularly on a translational research that incorporates various innovative methodologies and also highlights critical partnership that helps to strengthen and advance nursing science. As mentioned, and thank you for that kind introduction, I'm with the Division of Intramural Research with the National Institute of Nursing Research at the National Institutes of Health. It's a lot of words, in Bethesda, Maryland. So as you know, the National Institutes of Health, this is the campus, the picture. It's the largest funder of biomedical research in the world. You know, it's public funded. It has a line item from the annual President's budget approved by Congress. We currently have about 29 institutes and centers, each with a specific research agenda. When I talk about research agenda, for example, in National Cancer Institute, they focus on cancer. National Eye focus on blindness. For the Nursing Institute, it's a little bit nebulous because we have our hands on everything. So I will show you some of the themes that the nursing research has really been focused on based on input from the community. So in every institute, as I mentioned, 29 institutes and center, each institute has its own, have very similar program. You have an extramural and an intramural program. The extramural program receives the bulk of the budget of NIH. 80% that is mostly awarded to researchers and scientists around the globe, and mostly in the universities. The intramural is about 10% of the funding of the entire NIH, and we are a scientist that conducts our research within the campus of NIH in Bethesda or in Minnesota or Arizona or in Baltimore. So those are the 4 different campuses of NIH. In the intramural, we are about 1,200 principal investigators, but the main heart of the intramural program is really training the next generation of scientists. So we have a lot of postdoctoral fellows. I have a lot of postdoctoral fellows now and over the years, so we can train them about basic translational and clinical research. There's so many buildings that's dedicated on campus that's dedicated to different types of research activities that are part of the research enterprise. And at the heart of the campus is a 240 research hospital that we see all our patients. And this is the hospital. This is America's Research Hospital, the clinical center. This is where the entrance, and then this is the lobby. And there has been about 500,000 patients that has been seen at that hospital since 1953. And currently there's about 1,600 clinical research studies being conducted in the hospital. Everyone seen in the hospital, every care provided is free, of course, as long as you enroll in a study. So I want to give you a little career trajectory of where I came from as a novice nurse to an expert researcher, just to show you that, especially for the students out there or PhD students or even a bachelor's degree, that it's everything is possible. Any track that you're on, any career level that you're in, that you can pave a path to where you want to be. So I started as a nurse aide when I came to the United States in a nursing home. And then I became a wound care and ostomy nurse. And then I moved to a teaching hospital and became a critical care nurse and focused mostly on open heart surgery. It was the nursing home that I started as a nurse aide. And then this was the hospital, the teaching hospital, that I learned being a critical care nurse and became an open heart surgery recovery. These are some of my Filipino co-workers, Filipino friends that I worked with actually here in Texas. And then after that, I decided that, you know, I need to move forward with my professional life. The most logical step was to become a nurse practitioner. And I went and enrolled in a family nurse practitioner program and graduated in 2003. And after I graduated, the physicians that I worked with in the ICU said, why won't you join our practice? So I joined their practice as the nurse practitioner of that pulmonary and critical care practice. I did rounds in the morning, changed vent settings and start central line, those kinds of stuff. And then did clinic in the afternoon, mostly on COPD and asthma and OSA, sleep apnea, all those kinds. That was my work. But while I was working as a nurse practitioner in that practice, the local university, which is Old Dominion University in Norfolk, Virginia, asked me to become a member of their faculty. They were looking for a minority male lecturer to join their faculty. So I was interested to become a member. I thought that's really an interesting path to pursue. Considering my mom was a teacher, I've always wanted to teach as well. But I didn't have any experience, but they were kind enough to help me and mentor me to teach. And while I was there, the dean told me, this is the hospital that I practice as a nurse practitioner, and this is the Old Dominion University that I was teaching. While I was teaching there, the dean told me that they really like to keep me, but I have to obtain my PhD. So I said, "Oh, I'm done. I'm done with studying. I'm already with a nurse practitioner." I thought that was it. I said, "But I really love the people I work with at the school." So I said, "Why not?" So I'll go ahead and enroll. So I enrolled in a PhD school, and at the end of my fourth year is to do your dissertation. And I thought, having a dissertation and working full time is really very taxing. Why won't I join that together? Work and at the same time collect my data. So where else but NIH has all the data? So I applied online and they interviewed me, and I said, I'm gonna be there as a 1 year only to get my data, but also work as a nurse practitioner, and I'm gonna go back and teach. And they said, that's fine, we'll take you. So I did a PhD in my study on ocular sarcoidosis. That was also one of the clinic that I established in NIH, but also the clinic that I really worked with the pulmonary group in Virginia. So, and Sister Callista Roy was my mentor, and she's still a phone call away. She's been kind. She's been a professional and personal mentor. So she helped me with using her model to really understand why people are their quality of life decrease when their eyes are affected with the sarcoidosis, or their lungs. I thought because they can't breathe, because they can't see, that's what's driving their quality of life. But actually, I was very surprised. It's actually fatigue, because they're so tired. They're on steroids, they're on methotrexate, they're on several immunosuppressants, that they're just so tired at the end of the day or every day that they can't perform as mothers. They can't go out to dinner. They can't do anything because they're just so tired all the time. That's the one driving their quality of life. So I thought, I'm really going to look into that and see why people are tired. And I thought that was a really appropriate nursing question to ask, because no other discipline would ask that question. So when I was ready, I finished my PhD in 2007. I reached out to Nursing Institute. I thought, this is a home institute. Before I go down and go back to the university, let me ask them if they need any help. So I emailed and they said, come over. I thought it was just introduction. They actually was looking for 3 nurses to invest. The whole time that NIH has been in existence for almost 100 years, they haven't really invested in nurses to start an own research program. So it was just perfect timing when I joined them, that they wanted to have 3 nurses to start a program of research. So they said, what program do you want to start? And I said, fatigue. I thought, I was so naive. I was such a really early career. I thought that would be easy to study, and not knowing how nebulous and how complex that construct is. But these are the different themes that NINR was really focusing on: symptom science, wellness, self-management, and palliative care. We're more focused on symptom science here in Intramural because of our affinity to different labs and expertise on campus. So that's why we focus more on symptoms and its biology. So I led the symptoms biology unit. I had several staff. In order to really understand, I don't have experience in the lab. I don't have any, I think I was pretty sure I was a good clinician. So that was my strength. So in order to really build a program, I need to understand my weaknesses. And I thought that my weaknesses was really in the lab because I don't have much experience. So I hired different neuroscientists to help me understand the brain, to help me understand behavior. I had psychologists and geneticists to really help me to help me answer that question on why people get fatigued. And why symptom assessment, why understanding symptoms is critical, because that is the hallmark of our nursing practice. We are at the forefront of the healthcare systems, and when people come in, it's often their symptoms. They don't come to healthcare services because of they just love to see nurses. They come in because they have symptoms, and we are really fortunate to capture those experiences when they come to these healthcare systems. And that's why that's the uniqueness of our nursing practice than any other disciplines. And we all know that symptoms are self-reported perception, and they can be anything. Your fatigue and my fatigue may be different. These are experiences that are drawn way back when, from built over time through our experiences in life. And they have, symptoms have a lot of clinical and research and policy implications. As you can see, when, as a nurse practitioner, when I see a patient, when I see a chart outside a door and the chief complaint is fatigue, I scratch my head because there's really no treatment. You can advise them to say exercise or eat right or sleep right. There's really no treatment for that because there's really no studies that have been conducted on that issue. But patients are moved from one provider to another, and they sometimes really sent to the ER and really costing a lot of dollars in our healthcare system because there is no treatment. So my study was to really identify what's clinically meaningful fatigue, particularly in cancer. I chose cancer because most of the patients in cancer, oftentimes they have no fatigue at diagnosis. And then when they receive the treatment, they have this really debilitating fatigue. And over time after their treatment, there's really some patients that have resolution of fatigue while others don't, considering that they have, the same type of disease, they receive the same type of treatment, and yet subpopulations of patients continue to have that persistent fatigue. And I wanted to really dissect that experience of dimensions of fatigue. Are there different anatomical locus or circuits involved? Are there any behavioral biologic correlates of it? So I was using a symptom science model to really dissect the complex symptom, understand the phenotype. When you talk about phenotype, is BMI involved, is hemoglobin involved, all those clinical variables that can define that fatigue experience. And then through that, use that phenotypic characterization to understand any markers, and then target that marker for clinical application. So why is it important? Because fatigue negatively affects quality of life. It's very common, and it can lead to depressions, a lot of other symptoms, negative sequelae, and it also consistent with our mission at NINR. It has been described to be distressing, persistent, but as you can see, there's several dimensions. It can be physically, emotionally, and cognitively manifested. It can be exhaustion of those different dimensions. But fatigue and tiredness are different. When you're tired, you sleep, you take a nap, you get better. Fatigue, it's not related to your activity. It's not related to just treated with sleeping. It's more prominent of course, in cancer and cancer treatment, cancer survivors even, and those with chronic illnesses. There are two schools of thoughts out there that says it can be peripheral fatigue or central fatigue. These are just muscles involved. That are not, don't have enough output to meet the needs. But there are also central fatigue proponents that says, it's all mental, it's all related to depression or not sleeping, all those kinds of stuff. So that I thought, as I mentioned, the cancer-related fatigue was an ideal population for me. I started by really understanding what's the state of the science, what has been done in the literature. So I gathered several experts internationally to review the literature, and we found that there's really no validated marker of cancer-related fatigue. So I thought that's where the gap is, and that's where I need to focus my study on. So I reached out to the National Cancer Institute. They were kind enough to open their doors for me to see their patients. I followed, most of these are prostate men who have localized disease. I wanted to have a population that has a disease that's far from the brain, because I don't want to attack the brain, because I want to understand the peripheral and central interplay of this disease, of this behavior. Because I thought that fatigue is centrally driven. So I followed these patients before they were treated, and then weekly when they're radiation treatment, and then 1, 3, 6 until 1 year after they completed the treatment. Of course, I gave them questionnaires to answer. I collected blood because I'm interested to identify some markers. I also did some objective measures to see whether skeletal muscle is involved, sleep patterns are involved, or any cognitive impairments are involved. So I tried to understand what is this fatigue phenotype. I saw that most of these patients are not fatigued before the baseline, before their treatment, and at middle of their treatment, all of them are fatigued, and especially at completion, which is around day 42. But about 37 to 40% of these patients have continuous fatigue at 1 year, and yet the rest of these patients have resolved or even had better fatigue levels compared to this 40. So I want to understand why this 40 is really experiencing that. I looked at the hemoglobin levels, and it was correlated during treatment. It means that if their hemoglobin levels were declining, I'm sorry, my voice. Their hemoglobin levels were declining, the fatigue levels were associated with that during treatment. Thank you. But that relationship was not observed at 1 year. So this 1 year is really unique. It's different. It's not driven by clinical variables. It was not driven by a reduction in hemoglobin. It was not driven by their body weight. It was also not driven by age, because these are mostly elderly gentlemen. But it was driven by other symptoms like depressive symptoms, global pain, and uniquely for this population is their urinary symptoms, because they're treated around the pelvis. So they have this type of cystitis where they have irritable bladders, that they get up at night. They have nocturia often, and causing them to have a disruptive sleep. So I looked at our objective measures, the hand grip dynamometry, and we found that our fatigue patients at 1 year actually don't differ in maximum strength. When we told them to squeeze the machine as hard as they can, they're the same with the non-fatiguers. But over time, we saw that if we tell them to keep holding that strength, we saw that our fatiguers declined faster, a lot faster than our non-fatiguers. So it means that performance-wise, there is strength, but they cannot hold that maximum strength longer than the non-fatiguers. I looked at it, the reason whether there is inherent skeletal muscle defect. Of course, I cannot stimulate my older men, so I use a mouse model. I use a mouse model. I irradiated the mouse in the pelvis to mimic what our patients were receiving, and then I use a foot plate. I use a foot plate to and stimulated the sciatic nerve to see how much force they generate. And I saw that in gross motor, where there's a rotating rod, the mice, both the radiated and non-radiated mice, they all hang on to the mice together. So their strength is not different, but when I stimulated the sciatic nerve, there's also no different. In short, there's really no inherent muscle defect related to radiation therapy. It's just the performance over time that's we've seen clinically for our fatiguers. I've also looked at the cognitive performance of our patients. The patients, the Stroop is a classical testing for cognitive impairment. This is where the patient see different colors on the screen, and what color they see, they have to click the appropriate color on the keys, the computer keys. So we saw that the performance for both fatiguers and non-fatiguers are the same. They have accuracy of performance are the same, no difference. However, when we change the wording and the color, that's interference. For example, if we show the word red, but we paint it with color blue, the fatiguers are confused with that. So it seems like that is really the interference is the one that has a lot of problems with our fatiguers, not the accuracy of the task. And we also observe that in our mice, in our radiated and non-irradiated mice. For the Y maze, where they're moving around in a Y machine, there's no difference. But when we did a reversal learning, meaning we created a hole in the cage where we put a pellet, their food outside behind the hole, we trained the mouse that's the hole where they can get their food. So they learn pretty good, and then we switch the pellet to another hole, and the fatiguers take a longer time to find that hole, or the radiated mice take a longer time to find where that food is compared to the sham or then the non-irradiated mice. So we found that this fatigue behavior related to radiation is related to reduction in physical activity, but not really inherent to muscle differences, but related to reduction in performance over time. Time is a critical component, but this could be related to a motivated behavior. We cannot rule out that performance over time, reduction in the performance over time may be related to motivation. So that's what we're focusing on. And that could be one component of fatigue, is really on motivation. So our next goal is really investing in the lab and see whether we can identify some markers that we can target to be used for treatment. So we did two independent experiments. One is on genes. We looked at the RNA of the blood we collected from white blood cells, And we also did the serum and measured different cytokines, pro-inflammatory, anti-inflammatory cytokines. In the serum, we found that there's only one cytokine that really was high in our chronic fatiguers compared to our non-fatiguers, and that's what we call TRAIL. It's like a TNF. It's really a pro-inflammatory cytokine. Interestingly, though, the decoy receptor of this cytokine was also found in the gene. So we thought that's an interesting marker to follow. We validated it with another group of prostate men from another hospital, and we saw the same finding, and we tried to track the level of TRAIL in our patients, and we saw that the non-fatiguers, we saw that there's really a decline in the level of TRAIL at 1 year compared to our chronic fatiguers. So we tested if you expose different cells of your body to this TRAIL, to different concentrations of TRAIL, will they die? So we saw that when we exposed neurons, skeletal muscle, and microglia to cells, we saw that both the muscles and the microglia were resistant to the different concentrations of this TRAIL, of the cytokine. But the neurons are very sensitive. The TRAIL was toxic to this neuron. This suggests that perhaps high levels of this TRAIL in our chronic fatiguers may be causing some nerve damage that may affect some of this cognitive impairment that we saw. We also saw that, again, cytokines are very high, and that's also in our literary review. Inflammation has been a driver for fatiguers. Especially when you get a viral infection or you have a flu, you feel tired, right? Your body aches, you just don't want to do anything. That's inflammation kicking in. Your body is just reacting to it. We know that that's similar to fatigue. So we tested and see whether if we can get rid of inflammation, whether our mice can run faster. So we gave our mice added minocycline, a broad spectrum antibiotic in our drinking water of the mice. And we saw that those mice treated with drinking water ran more and faster than those that were not treated. That's after radiation. But because broad spectrum, we can't really treat our fatiguers with just broad spectrum antibiotic so they can feel better, because that will also affect their tummy. So we found some gene, and we MYD88 that is responsible for activating your inflammation, both acquired and innate. So we reduced the expression of that gene, and we found that gene with deficient MYD88 were also running faster, meaning this confirms that inflammation, if you really reduce inflammation, that improve or reduce your fatigue. We've also optimized using data analysis, and all these are really through partnership. We collaborated with our Harvard collaborators, especially in bioinformatics, to understand any predictors, genes that are predictive of patients. Before they come into the clinic, we can predict whether they will develop chronic fatigue, even before starting their treatment. We saw that patients who carry these different genes are most likely to develop chronic fatigue at 1 year after completing their treatment. And most of these genes were glutamate receptor. So we thought that's really interesting. Why glutamate receptor? And you know that glutamate receptor has been an active target for psychiatry, for mood disorders. So we thought to answer what is the relationship of fatigue? We know that fatigue and inflammation are romantically linked, but what is the link of glutamatergic system with fatigue and inflammation? we saw that when we enhance these glutamate receptors after radiation in the white blood cells, we saw that it gets very angry, meaning there is a lot of inflammation in the T cells. It's activated. But when we inhibit this glutamate receptors in the cells, it looks like it's normal. It looked like it's behaving, even if it's irradiated, it's behaving like it's non-irradiated, like a healthy cell. And when we squeeze these cells, we measure the cells, we found that the RANTES, which is a marker for T cell activation, which is a marker for inflammation, that it is higher in these cells that have been activated or pre-treated with agonists of glutamate receptors, while the cells, the lysates of the cells that have been treated with inhibitor of glutamate receptor have lower levels of inflammation, of RANTES, T cell activator marker. So we thought, if we inhibit glutamate receptor, we might improve fatigue levels of our patients. So I reached out to our psychiatrists here at NIH who have targeted glutamate receptor. They use ketamine, special K used in parties and in veterinary in horses. They've used a really low dose of ketamine, and they found that 40 minutes after infusing ketamine, they observe a rapid antidepressant effect. They've now giving it to suicidal patients, and 40 minutes after, these patients just become like normal. Like the blueness becomes normal, which is really very revolutionary for psychiatry, because as you know, most of psychiatric drugs takes weeks, 4 weeks to work, but with ketamine, it works very quickly. So we thought it could work as well with fatigue. So I am conducting a study. I'm giving 1 single dose of IV ketamine. I'm using Versed as a placebo, active placebo, to mimic the anesthetic effect of ketamine. And so far, that is ongoing. And so far, patients that we've given ketamine, one patient actually had a blog and was interviewed by a local paper. He said that after he gave the ketamine, he was about a 42-year-old cancer survivor who had a lot of, who's an IT person. And in the afternoons, he's just totally out with no energy. But after we gave the ketamine, he has so much energy that he has to climb 3 floors, which he hasn't done in the past, just to release that energy. And it lasted for a few days, 2 to 3 days, the energy, and it went down back to its normal. So we're very excited about the initial results of this study. We've also found that people who are carrying a specific allele, BDNF allele, have higher fatigue scores compared to others. So this could help answer the next question, whether fatigue may be genetic or not. So we're exploring that further in different clinical populations and different cancer populations. Currently, nurses are forced to educate patients by exercising as one of the main management of fatigue, and without the science behind it. Not all patients can exercise or even like to exercise, but this is our nursing student in the CAP, and our nurse who is on the treadmill. So we are exercising patients. We have 2 arms. One is a continuous training where patients, we raise the heart rate 60 to 70% from the baseline, and for 30 minutes, while the high impact is just 1 minute of increasing the heart rate to 90% and then stopping for 2 minutes and then go back again, eight repetitions. And the patients, older patients, even are 80 years old, really like the high impact training. We saw that the WBC, when we measured, this is like a PFT, a pulmonary function test of the white blood cells. We found that the maximum respiratory rate, a maximum respiratory potential of the healthy individual are much higher compared to our fatiguers, meaning that when you add another stress, if you let them exercise, our patients have no reserve capacity. They cannot, their cells are not able to accommodate that another stimuli or another exercise. We found that with exercise, this is measured at baseline, the orange, and then the gray is 24 hours, 48 hours, and 72 hours. This is actually the first data that show that exercise, even a 10-minute exercise, you can see that for 72 hours, it's like flourishing, like your white blood cells are breathing way deeper than not exercising. But over 24 hours, even just one 10-minute exercise one day, your cells are really happy. They're breathing better, deeper. So over time, these are my trainees that are now in different universities across the world, actually. And I have trained in the lab, and I'm very proud of them. And also my hardworking fellows in the lab and in the clinic that has helped over time in making sure that we move forward with our science. That's my presentation.
Dr. Leo, that was such an amazing presentation. That was great, and we thank you for bringing nursing forward as a force for a catalyst of change. Thank you again, Dr. Leo.
All right, thank you. And if you need anything else, please contact me, and I would love to chat with you.
Okay, thank you, everybody. That was a wonderful presentation. Yay!
I know. Thank you so much.
Thank you.
It was really a great presentation.